I'd like to introduce Alyson Murray. Alyson's going to talk on allergies and intolerances in babies. Alyson is a practitioner passionate about the health and well-being of babies and children. Prior to qualifying as a chiropractor, she spent over 20 years as a paediatric nurse and a midwife. Her approach is holistic and incorporates chiropractic plus allergy intolerance management. She continues to work at the Royal Children's Hospital in Melbourne, and in her chiropractic practice, Alyson exclusively works with babies and small children. Alyson.
Hi. I haven't got my notes because it's a different sort of format to what I'm used to, so I'm just going to wing it, guys, okay? I'm just going to put my hand up and go, I'm not an expert in allergy, I'm not an immunologist, but I do have a special interest and I do a lot of reading. This is such a massive, massive subject that it was really actually hard to pull it down. I wasn't really sure what my audience was and what level I needed to pitch it at. So what I've gone for is just a general overview of the subject and just touched on some of the research that's out there and where it's sort of heading. So this is sort of currently where we're at and what we know. This is from ASCIA. So these are this is the peak body on allergy and immunology in Australia. This is their statement on the reason for the continued use, the rise in allergic disease and food allergy and eczema. They said it's complex, it's not well understood. Although infants with a family history of allergic disease are at increased risk of developing allergies, infants with no family history can also develop allergies. Now, I went to their conference 4 years ago in Adelaide, sort of to see what they were saying, and it was interesting. So when they got past all the speaking, they all said the same thing. They said, where is our food being produced? Which was, I thought that was quite interesting. Everyone's on the same page. They also said that the National Health and Medical Research Council weren't willing to fund research into eczema because they didn't think that the burden was big enough. And I strongly suspect that babies don't vote. So I attended a session at the Royal Children's last year, again, on allergy, run by the same organisation, and there's a lot of research there now. And it's now mandatory to report all presentations of anaphylaxis to emergency departments. So we've come a long way in 4 years and they realise we've got a problem. Now, so the current advice for food allergy, this is from ASCIA, risk factors. So this sort of demonstrates that they still don't really know much. So they're looking at the risk factors if you've got eczema or immediate family history. If you have severe eczema and an egg allergy, then be careful when you have peanuts. I mean, this is pretty basic stuff which most parents are aware of. Recommendations, solid introduction between 4 and 6 months, and I know there's a lot of confusion out there around this, with some districts advising parents to start at 4 months and some advising to start at 6. I say start between 4 and 6 and when your baby is ready. Common food allergens should be introduced before 12 months, and interestingly enough, cashews are a bigger issue now than peanuts. Breast is best, but if unable, then a standard cow's milk formula. IgE, so the current medical model basically focuses a lot on looking for the IgE, and if the IgE is there, then we're looking at allergy. Now, I should really define allergy versus intolerance. So an allergy is pretty well known as being something that may cause a life-threatened event, versus intolerance is when you get symptoms when you consume the product and the symptoms go away when you don't eat it. So the IgE, so if you're referred into Max or somewhere like that at the Royal Children's, they may do some skin prick testing, which again, it's looking for IgE, and they'll do little pricks on the skin and put little substances on the skin. Accuracy depends on the quality of the substances they use, and it depends on the skill of the practitioner. So they have to be a certain distance apart. Cross-contamination's a big thing. I get some interesting stories from some of my parents coming in, and you know there's been cross-contamination. Infants, they've got an immature immune system, they may not fully react. So it's not reliable in infants. RASP, which is a blood test, which has pretty much been superseded by the ELISA test, again, looking for IgE antibodies in blood. Children may be positive, but demonstrate no clinical symptoms. A negative also, there's still caution there because they can come up negative, but there can still be issues there. Now, patch testing, which I haven't really come across much of, where they put a paste of the substance applied directly to the skin and see if it reacts. And then blind oral food challenge, which is the gold standard. So they don't know what they're eating, they eat it, and they react to it. There's obviously dangers involved there. That's the IgE. Then we've got the non-IgE mediated gastrointestinal food allergic disorders, which not everyone's aware of. So you've got FPIES, which is becoming, it used to be pretty rare, and I'm coming across more and more of it. You've got food protein-induced enteropathy, and you've got food protein-induced allergic proctocolitis. Diagnosis relies on a symptom pattern and a biopsy for FPE, and the pathogenesis is poorly understood. I'm seeing a lot of bubs come in with blood in stool, and they're automatically being assumed to have an allergy, but it can be a non-IgE. Now, basically, just covering FPIES, it can be acute or chronic. It can start from birth to 1 year. It is really commonly seen with the first rice cereal, if that baby reacts to rice because it's a protein. They vomit. Often they'll vomit pretty quickly. They go pale and floppy. Usually an ambulance is called. They present at the ED. They can have low blood pressure, but there's, to the best of my knowledge, been no fatalities. There is an allergic component. Eosinophils are prominent, and cow's milk, soy and rice are predominant. And interestingly, the article mentioned Australia for rice being a big problem in Australia. Yeah. This one, so 6 months, the average is 2 to 8 weeks. They get intermittent blood in the stools in an otherwise thriving infant. Again, eosinophils are prominent. Food challenge will create rectal bleeding within 6 to 72 hours. Cow's milk, soy, egg, wheat, or through breast milk. And it has been seen with your neonates and early cares. Extensively hydrolysed, that's more Pepti Junior and Alfaro, but it's rare. FPE, 2 to 24 months, and this one's pretty much mainly about diarrhoea. No eosinophils, reintroduction, within 40 to 72 hours they'll react, and cow's milk is the most common, but also includes eggs, soy and wheat. So that's roughly a very basic overview of what we know. So, but what are we learning? What's out there in the literature? What are the scientists discovering? So this is when we get into the world of epigenetics. So this is a process where genetic information is translated into the substance and behaviour of an organism, specifically the study of the way the expression of heritable traits is modified by environmental influences or other mechanisms without a change to the DNA sequence. So basically you can modify your genetic material by your lifestyle. Epigenetics, it's determined by the health of the cell membrane. So each cell membrane contains roughly 100,000 protein switches. So if you imagine a balloon with all these switches on the outside, and the environment is basically everything outside that cell, so anything that reacts with those switches and can change those switches can change the signal that goes into the nucleus and therefore can change your DNA. So we mentioned things here: drugs, food, chemicals, stress, family history. And when you're looking at pregnancy and things like that and interventions, you can see ways that this is being modified. Endorphins, stress hormones, nutrients, starvation, inflammation, non-inflammation all affect the membrane. Your cell environment. So we want it to be in an anti-inflammatory state for optimal functioning. So that this is all chemistry. We want excellent nutrition, and we're feeding genetically modified food now, and if you start researching that, you'd actually be horrified. Healthy microbes, which Tamara's talked about. You want your baby to go to term. I work with prem babies, and it's not good for them to come out early, I can tell you. We want a normal birth, if we can help it, and we want breast milk, and we know these are ideal situations, and not everyone. This is not achievable for everyone. Inflammatory, seasonal affective disorder, dysbiosis, a managed gestation. I see a lot of inductions, a lot. Medical births, formula, antibiotics and stress. So you've got inflammatory will change, that creates increased cytokines, you've got histamine and you've got cortisol, which affects the cell. Contributing factors. So dads have got away with things for a long time, but not anymore. So we now know that they're contributing, that sperm is contributing to the egg. It's kind of a 50-50 contribution. So they need to stay off the plonk and they need to clean their act up a bit before contributing. Mums have been in the firing line for a long time. And I'm seeing, I've got no stats on it, but I'm seeing differences in those girls who are going to naturopaths before pregnancy and or during their pregnancy. I'm seeing a difference in the babies. Not always, but definitely there. We're looking at interventions during the pregnancy. Now, if you've ever put a CTG machine on a baby that's sleeping, it gets this flurry and it moves away from the CTG, from the ultrasound. It's stress. They don't like them. Birth method, high interventions, feeding method, it's all there. Okay, preconception. So we now know that feto-maternal tolerance is initiated by the presentation of paternal fetal antigen from semen. So this is before the egg is even implanted into the uterus. So that immune system's kicking in. Sorry about all the writing, guys. I couldn't remember all this stuff. Okay, so pregnancy. So the mother automatically adjusts to an anti-inflammatory state to prevent rejection of the fetus. And these maternal microbiome, it's specific to pregnancy. Observations suggest pregnancy is associated with an altered Th1, Th2 balance, and we've known that for quite a long time. We have antigen-specific memory cells, Tregs, which are suppressors. They dampen everything down, and they assist this fetal-maternal tolerance. The immunological relationship is bidirectional, determined by fetal antigen presenting, and then the mother recognises and reacts to it. The fetus is known as being semi-allergenic, and it means that part of it is, the mother's body recognises part of it as being part of her, but they know that part of it's not part of her because, of course, it's part of dad. The fetus is gradually being taught how not to respond. The baby is bathed in stem cells. Now, those stem cells will go on to differentiate into cartilage and cardiac cells and gut cells and all sorts of things. And babies swallow, they urinate, they breathe this fluid and they're bathed in it, and then they've got substances coming through the placenta and the cord. There's now evidence that immunological recognition of pregnancy is important for the maintenance of gestation. So they're actually thinking in some cases that this is causing premature births. And the maternal microbiome has been linked to outcomes known to adversely affect neonatal and infant health. Then we move to labour. Labour resembles an inflammatory response. So you get a secretion of cytokines, chemokines by resident and infiltrating immune cells into reproductive tissue. So they go from a low inflammatory state to a pro-inflammatory state. The microbiome again changes during this time. The Tregs that were suppressing everything are greatly reduced, allowing the body to get into this pro-inflammatory state. Adaptive immune cells participate in the tolerance, and maternal leukocytes, white blood cells, are recruited to reproductive tissues by chemotactic processes, probably initiating labour and delivery. And they now know that T cells are being found at the site where the membranes rupture. So they're rushing to that site. So they're thinking that some sort of an immune reaction that the baby says it's time to separate and it's time to come out. 40% of blood can be left behind if the cord is clamped immediately, which affects catecholamine release, which jumpstarts the immune system and leaves them anemic. Results indicate lactobacilli may influence the development of the neonatal immune system, and antibody prophylaxis in labour is associated with dysbiosis. And there's a lot of that happening, and I know some hospitals, it's routine. I know when I take a history of some mums coming, and I've worked a lot of units in Melbourne, I know which ones use the antis and which ones don't. And some of them is just standard, particularly with the Caesar. Now the neonate. They are in an anti-inflammatory state for 2 years, and they're progressively and slowly moving towards a pro-inflammatory state. The reason they're there is to allow for tolerance. So their immune system is learning and developing tolerance. The breast basically takes over the role of the placenta. And I say to my mums, you've signed a 2-year contract. You don't realise it when you do it, but it's a 2-year contract. And those breasts take over the role of the placenta. The infant gastrointestinal system, the microbiome is established, as Tamara mentioned. The system needs to know when not to react, and our babies are not managing this step. Early antibiotic exposure was significantly associated with level of food allergy, and we need a stepwise microbial introduction is important to get the balance, and that starts in the uterus. Breast milk, well, that's a whole nother story. And I'll just touch on breast milk because that's just a talk in itself. So basically it's microbial DNA. It's a white liquid. We call it milk, but it's not. It's a white living liquid, and it's a live transplant from the mother. The maternal bacteria pass from the gastrointestinal tract to the mesenteric lymph nodes, which travel via blood and lymph to the mammary glands. Particles from the mother's body are encapsulated in milk and then pass on to the neonate. Breastfeeding has a direct influence on the microbiota, and indirect via HMOs, which are oligosaccharides, secretory IgA, and antimicrobial factors. The microbiome, which is Tamara's, and I've just touched on. So we're looking at the order and timing of colonisation and the lasting impact it has and contributes to variation between individuals, because we know that there is no perfect microbiome. Important role of nutrient and bile acid metabolism and production of vitamins, and the microbiome plays a role in this, and colonisation and signalling by microbes plays a pivotal role in both gastrointestinal mucosal immunity and systemic immunity. So I'm thinking you need to get a dog, and you need a dirty dog, because the evidence has shown that having a dog reduces the incidence of eczema and allergies. Yep. Thank you.